Welcome, everybody. Thanks for joining us today and coming to our table. Thank you for joining us today. It's going to be a great presentation. A lot of interest for this. Talking about the workforce crisis and taking a deep dive into DSPs. Welcome and thanks for joining us today. We're just waiting for people to file in the room. We had about 250 people sign up for this webinar today. Lots of interest about DSPs. So just a moment, we'll get started.
Beth, you can go ahead and start.
Thank you, Devika. Welcome, everybody, and thank you so much for joining us at our table today to talk about Help Wanted, the workforce crisis, where we're going to take a deep dive into DSPs with Pat Porter. I'm Beth Field, and I am the Program Director for the Leadership Alliance for Neurodevelopmental Disabilities. And we're the initiative that is the backbone to drive this Meet the Need NC initiative, which is to meet the service and support needs of the IDD community in North Carolina. We have inclusive accommodations today. We have ASL interpreters, as you see on our screen. We have Spanish translators and court captioning. Murtado, would you like to say a couple bits about our Spanish translation today?
Yes, thank you very much, Beth. And I'm going to just introduce the space so that we can participate in Spanish if we want. So just for the English speakers, please speak at a moderate pace so that interpretation can happen both for the Spanish interpreters and the ASL interpreters. Muy buenas tardes o días. Bienvenidos a esta gran reunión, el Lunch and Learn, que vengan a almorzar y a aprender, donde nos van a compartir información muy importante para todos. Para participar en español, tenemos en la parte inferior de la pantalla de su computadora, ven un globito. Hagan clic en el globo y seleccionen español. De esta manera pueden escuchar esta magnífica presentación en español. Si se conectan desde una tableta o desde una computadora o desde un teléfono inteligente, por favor vayan a los tres punticos y seleccionen interpretación del lenguaje español para escuchar todo en español. Thank you very much, Beth. I also want to remind everyone that this will be also recorded in Spanish and the link will be available in Spanish for those who may have not come but want to use it later. Thank you very much. Back to you, Beth.
Thank you very much, Murtado. And we know that we've got some new people coming to the table and ones who may have been joining us since our January Lunch and Learns. And we're going to continue on with part 2 of this in October. I just wanted to quickly introduce our speaker today and talk a little bit about how we're going to go about Dr. Porter doing her presentation and then how we're going to move on to Q&A. But let's switch screens here. This is Pat Porter, is the former clinical director of the UNC Division for Disorders of Development and Learning, now called CIDD, or the Carolina Institute for Developmental Disabilities. She served as the Chief of Developmental Disability Services for North Carolina, during which time she directed programs for adults and children with developmental disabilities. She also established the NC Self-Advocacy Association and the Developmental Disabilities Consortium. As Senior Policy Advisor to the North Carolina General Assembly, she provided expert support in areas of health policy to include Medicaid, managed care, and developmental disabilities. She currently serves as a member of the affiliated faculty for the UNC Center for Literacy and Disability Studies, and is advisor to the Innovations DSP work group. She has many awards, which include the I2I Lifetime Achievement Award, the ARC President's Award, and the North Carolina Council on Developmental Disabilities Holly Riddle Award for Distinguished Services. She has spent her entire professional career in partnership with and support of individuals with developmental disabilities. What an amazing profile here about Pat. I just wanted to mention first that we're going to, as you're listening to Pat, put your questions in the Q&A box, not in the chat box, in the Q&A box. And we will then move to questions after this with John D'Angelo, who is a person with an IDD, and also Ann Rodriguez, who's a family member of a person with an IDD. We are all with LAND, our Leadership Alliance for Neurodevelopmental Disabilities. We are all people with lived experience, so we live this stuff too. I am now going to say welcome, Pat, and thank you so much for taking the time to do this at this very important time. It's so very timely based on seeing the budget yesterday that came out with the General Assembly and all the work that you have helped forward with many advocates. So please take it away. Thank you.
Well, good afternoon. I'm very pleased to be here, and this is a very important topic and very timely right now. I'm going to talk a little bit about that. I'm going to move swiftly so that we can get to questions and answers. I want you to be able to ask what I haven't covered, items that I may not have covered here. I also want to say this is part one of a two-part presentation. So let's get started. Slide one. All right. I want us to get into understanding some general terms. We sometimes proceed through a discussion and don't really understand that the person we may be speaking with has a whole different idea about what we're saying. So at least for this presentation, I want to go through these. This is crisis, time of intense difficulty or trouble. But in addition to that, it's a time when difficult decisions need to be made. That's the active part of crisis. IDD, intellectual and or other developmental disabilities. DSPs, direct support professionals, also called direct support staff, personal care assistants, direct support personnel. And for the presentation today, and I think in general, as we speak about these folks, we're speaking about unlicensed personnel who deliver the services included in the individual service plan for a person with disability. Now, these are other than licensed professionals, that is nurses, psychologists, social workers, physicians, those folks who must practice under a license. Innovations is a Medicaid waiver program for people with IDD. So when I talk about innovations, that's the innovations waiver. Another thing I'll speak about today is COLA. You'll hear people talk about COLA a lot, and it's a cost of living adjustment. It's an automatic wage increase that's annually determined based on a formula that includes what it actually costs to cover living expenses. And I'll talk a little bit more about that as we go on. Next slide. All right, a little bit about the history of the DSP workforce. Let's start with the state-operated DD centers, now called developmental centers. The important things to know about DSP staff within those centers is that they are well-trained staff with required standard curriculum. They've been trained with the standard curriculum, working under the direction of skilled and experienced supervisory staff. I think that's very important. Consistent curriculum makes a difference. Second, they have backup staff and licensed staff available on site. That is, they can call the dentist, they can call the doctor, they can call the nutritionist, a behavioral support staff, and they're on site. They offer assistive technology, adaptive equipment, again, nutritional support, and those are all available on site. Those are full-time folks that work within the centers. They used to, I don't think they do this anymore, but they used to provide training and support to community DSPs. We would often bring folks who were hired as DSPs into the centers to provide supervised training and on-site training, and then we would move into the setting in which the DSPs would be working and supported them there. That was a really good idea. They're state employees, so they are provided a very good salary and benefit, pay raises, and COLA. Likely there will be a pay increase for them during this session of the General Assembly. Every time state employees get a pay increase, that pay increase also goes to the DSPs in the facilities. Okay, next slide. The next group that I would like to talk about per DSPs and the history of DSPs are group homes. Group homes have on-the-job training with some standardized instruction. They have backup staff, if needed, on site. They have supervisory staff accessible to them and providing supervision. They have access to licensed personnel as needed, not on site, but if they need behavioral intervention, if they need a psychologist, if they need a physician, they usually have those under contract, those folks under contract. So they have licensed personnel as needed. They make a reasonable salary with benefits, some wage increase over the years. However, automatic wage increases and COLA are not available to these folks as they are with the state facilities. Next slide, please. In-home supports and services. This is kind of what we're talking about a lot today. Some training available through providers. Most training, as you all know, is provided in the home by family members, parents and family members. And that's an important consideration. They're supervised by qualified DD professionals or QDDPs. Various curricula have been piloted through the years within our state to lesser and greater success, although none of them have ended up in what we had hoped we would have, and that's a required standardized training in place. We certainly don't have that in our state right now. Initial salaries were similar to the DD facilities, but increased rates and wages did not apply to in-home staff over the years. And that has taken us to sort of where we are today. Next slide. The workforce crisis is everywhere. I can't underscore that enough, especially in community and in-home supports for people with IDD. It's all over healthcare. CAP-C for medically fragile children, CAP-DA for elderly and disabled adults, ICF group homes, other group homes, personal care services, as well as licensed professionals. Everybody is working under the workforce crisis. We are seeing 26% vacancy, staff vacancy in our own Department of Health and Human Services. A similar number to that in our state facilities. And so everybody is dealing with workforce crisis. States across the country are struggling to solve the problem. Some have been successful, more successful than others. We certainly can learn from what other states have been doing, but we need to be cautious about assuming that these successes in other states will necessarily apply to us. Each state has a different organizational and operational system. Ours, for instance, contains the public behavioral health, IDD, and traumatic brain injury system, the LME MCOs, and we've been operating under managed care for those populations since 2011. Really unique across the country, but there is a potential upside for those of us who are looking for workforce solutions. COVID made the problem worse and revealed weaknesses in our system, no question. The emergency required flexibilities and to assure that essential workers, the essential in-home staff, would be available, and to keep providers running. Many provider agencies closed during COVID because they just couldn't afford to keep running. We lost a lot of DSPs because we weren't able to enter homes because of the pandemic. And so those folks moved on to different jobs. We can talk about Appendix K. For a long time, you know that was the federal allowances for the states to assume some flexibility to address COVID. And there are a number of those important, and including a 15% increase in rates, allowing families to provide services to service DSPs for minor children, and to increase numbers of hours for some folks. And there were other things that were provided to make sure that providers were able to endure the pandemic and to make sure people got services. Now, why do I mention that? Well, it's because those flexibilities are supposed to end in our state in November. These were only temporary allowances across the country for most of the states. And when the pandemic crisis ended, these flexibilities were meant to end. We have expanded those a couple of times. The Centers for Medicaid and Medicare allowed that to happen, and most states went in to ask for an extension of those. We're in the process of talking about to the department about further extension of some of those. The DSP work crisis is not a new problem. We've known about it for years and years and years. I don't think there's been an understanding of the impact of the lack of access to DSPs, certainly not in the General Assembly, and certainly not in the public at large. And so part of our effort has been to inform and educate about the crisis. Obviously, the ultimate goal is to be able to recruit and maintain a cadre of high quality DSPs. That's our goal. Next slide. What is our focus? Well, for right now, the groups that I'm working with have decided to zero in on the innovations waiver. Why? Because innovations provides the largest sum of money paid in support of people with IDD in our state, the largest amount of money. That's not insignificant. That's not an insignificant consideration. Innovations is a home and community-based waiver focusing on in-home support. Innovations DSPs are the lowest paid DSPs in the state. Average $11.50 an hour. That's some of us think outrageous. Just for comparison, the DSPs in our state facilities have a base salary of $18 per hour, and that will go up as pay increases go up. That's reflected in their salary. So they have a base of $18, and the folks in innovations make $11.50. Innovations DSPs have no professional organization like the nurses and psychologists and physicians do. They have no lobbyists, as the ICF group homes do, and nursing homes and PCS groups do. That is a significant element in the lack of attention that we've had to the DSP crisis. As important, perhaps more important, is all decisions are made and have been made based on no reliable data. We haven't known the numbers of DSPs working in innovations. We haven't had average hours they work, the turnover rate, how they're supervised, how many of them are allowed benefits and how many not. All of that information was not available. Very unique because most of the other DSP situations do have that data. I'll be talking a little bit more about that, perhaps not in part one, but certainly in part two, because data is what drives our bringing attention to this issue. People want to know what the numbers are, and that makes sense. The vast majority of approved services in the innovations waiver are delivered by DSPs. Now think of that again. If we don't have DSPs, it is predictable that people are not going to get what they need, and we have to begin somewhere. Success in the effort to recruit and maintain DSPs is going to be an effort that requires laser focus. Sometimes when we dilute our requests, we add confusion. I'll talk a little bit more about that as well. So can we move on to the next slide, please? The impact impacts everybody in our world. Individuals are impacted. There's a very large gap between authorized services and delivered services. People are not getting the services they need. Simply, they are not. Now, I add a little caveat to that and say, in North Carolina's contract with the Centers for Medicaid and Medicare, there is a solid and firm agreement that if it is determined that individuals have medically necessary needs, the state is required to provide for those needs, to provide services. So right now we're out of whack with that. CMS understands and is paying a lot of attention to the DSP issues, but that is an important consideration. Families. There have been a significant increase in the number of family members who are serving as paid DSPs, not necessarily because they want to, but because there's nobody else to serve their loved one. One provider told us that 50% of the DSPs working for that provider, 50% are family members. And it's because no DSPs can be found. Parents and family members have had to quit their jobs in some instances. Some are considering moving their family member to institutions because they just simply can't manage the care at home. Providers are impacted. They frankly get paid for delivering services. If they have no one to deliver those services, there is a crisis. A number of providers have had to close their doors. If we don't have sufficient providers to deliver services, we're in trouble. We all need one another. DSPs and the impact on them, I think we sometimes don't consider how much impact this has all had on them. Many, in fact, most of them are working two jobs to support their families. They have low wages, burnout. Some of them try to work overtime if they can, but the impact of having to work a second job is significant. The majority of them are working in situations where there are no benefits. Some of that is because the DSP is working part-time instead of full-time. One extra added attraction of Medicaid waiver, a Medicaid expansion in our state is this. Many of the DSPs will be eligible for Medicaid services because of the changes in the Medicaid waiver. Those DSPs who may not have health care coverage right now will have health care coverage, most of them. The bottom line is this: if there are no DSPs, there are no services. It is as simple and as complex as that. Let's move on to the next slide. The future. The situation is getting worse. We cannot fill the DSP need now. I just spoke about that in the last slide. The addition of new innovation slots, we expect to get at least 350 in this session of the General Assembly, and the implementation of the I option, which has already started, will increase the need. Anybody who gets an innovation slot and anybody who is served through the I option will need DSPs to deliver those services. So that will cause the workforce crisis to get worse. Now, what we don't want to do is connect those things. We don't want the General Assembly to believe that they ought not provide new innovation slots or implement the I option because we don't have enough DSPs to cover those folks. What we need them to understand is we need more DSPs, and they are instrumental in helping us provide that. We really have no choice. We have to be able to recruit and maintain adequate numbers of these essential staff. Now, this is an important thing to consider as well. Our state, for many years, has strongly supported individuals living in the community, living in their family homes, living in homes of their own. It's simply imperative for the state to organize, to operate, and to fund all systems to make this priority happen. You can't just say we want in-home services, we want to support people in-home, and then not be able to put your money where your mouth is and put your organization around this particular effort. Can we go to the next slide? All right, barriers. We know there's a crisis. You know it probably better than I do. The department, in conjunction with the Centers for Medicaid and Medicare and the General Assembly, have to recognize the immediacy of the crisis and take all steps to resolve it. This is a joint effort. We got to get public support for it too. We have to be laser focused. And we have to assure that the message is firm, clear, and unmistakable. Many of the policy decision makers, members of the General Assembly, and others just don't understand the scope of this crisis. We often use the word crisis, overuse it. It's not misused in this situation. In review of all data, increase in wages is by far the most important factor. We looked at all kinds of supports that it would take to be able to recruit and maintain DSPs. By far, the top of the list is wage increase. Benefits come second, with credentialing, standard curriculum, and career ladder way below the first two, frankly. But this is not an insurmountable problem. Next slide. So what do? We need to be strategic. We are not often strategic. We throw the problem out, sometimes not to the right people, sometimes not with the right goal. We have to be crystal clear about the goal. We have to join forces. All of us together have to go forward with the same message and the same request. We have to understand that success in achievement for one group, increase in wages for one group will increase attention to all groups and serve as a model for future success. Very difficult in our state for one group to get a pay increase and that not have an impact on all other groups. It's very important to take all this together, all of the joining forces, to convince decision makers that there's a crisis. Last thing I'll say about this is that individuals and families must take the lead in this. You know, too often professionals go out and advocacy leadership goes out, lobbyists go out, and what we need and what will make the impact will be for the real stakeholders to take the lead in this and talk about from their heart and from their experience what impact this workforce crisis is having on them. We need to take a good bit of time to look at specific solutions and next steps. Now, this is a little teaser. That's what we're going to do in our next presentation. So tune in for part 2. Now ready for questions and answers.
Thank you so much, Pat.
Sorry.
Go ahead, John.
Yeah, thank you again, Dr. Porter. A lot of really great information, not only on the history of how we got here, the impact, and I think most importantly, the need for laser focus on the issues in terms of being able to educate decision makers. And I agree with you wholeheartedly about data. Should we go to the first question?
Sure. Well, there's one very simple one, Pat, so I'm going to ask you the two that I have, and you can answer both of them. The first one is just of in your slides, and you may have even answered it with a slide that came after the question was posted, is does group homes, your definition of that include ICFs? So that came up on your first slides when you were describing the supports and wages and things, the structure that DSPs have in group homes. The other question that's come up is, do we have data on the average cost to care for and maintain an IDD individual in an institution? Are these aggregates used to petition for how this savings can benefit the wages for recruiting DSPs?
That's a good question. The federal government, almost 85% of the money used to support people in our state facilities, federal money, because they are ICF, IDD facilities. They get per diem, which means they get an amount of money for every individual that they have or every bed that they have available. And so there is a way to determine how much money is paid per individual in our IDD state facilities. I ought to add, though, Keep in mind all those things that I said that are available in state facilities that aren't available through innovations waivers and in-home programs. Sometimes people are inclined to compare. Well, it costs this much money to support somebody in state DD facility, and compared to innovations, that's really quite a lot. You can't compare the two. So yes, we can get that information, but I would hasten to say no comparison between innovations and DD facilities. We can make that comparison if we're ready to look at all of the aspects and then compare apples to apples.
I think John's going to ask the next question.
Sure. This next question is, how does DSP solutions for IDD impact those for the aging population in terms of those issues being linked?
Yeah, that's a good question. And as I said before, anytime you focus on one group, because that's what you need to do to achieve success, it necessarily impacts all groups. And so this will serve, if we are successful in this, this will serve as a clear and strategic model for all other groups, including the aging population. I hasten to add, we've got a whole lot of people with IDD who are aging. So there's some intersect with that. I could go into more detail about that. Again, the aging population, folks in nursing homes, for instance, are managed considerably by licensed staff, by nurses. And I also say that there's some funding in the budget for nurses, funding for personal care staff. And so there's something going on. But I would say that the biggest thing is if you get success for one group, it filters to other groups and can be used as a model, should be used as a model.
John, could you please go with the next one? Anna's just lost her internet. So if you could hop in, that would be great.
Sure. Innovations providers were encouraged to increase to $15 an hour. Has there been any data to follow up if those wage increases were actually happened?
All right. There are two issues in that one. What you know is that, as I alluded to, during COVID, during the emergency, a lot of group homes were given additional funding, as much as 15% increase in rates. Because of that, they were asked to increase wages for DSPs, and most of them did that. We can look at those, although there's no accountability data on that. We believe that most of them did that. Some of the LMEMCOs, those who had additional funds, it's different across the state, were able to increase to $15 an hour, but it was variable across the state. We could spend a whole lot of time talking about that. But I'll just say some got $15 an hour, others didn't. We got funding in our state for home and community-based services during the last session. And we were supposed to use part of that to increase funds for innovations waiver and other HCBS services. I think personal care services were contained under that. And there was amount of money, a general amount of money coming into the state. And that money got spread pretty thin most importantly, there was no accountability. That is, providers got money. They were directed to spend it on direct support staff and a portion of it for administrative costs. And then we ended up with many, not most, of the providers keeping most of that money and not paying it out to DSPs. There are a lot of reasons for that, because they lost money after the pandemic and needed to fill in with some of that money. So the lesson in that is, if we get new money earmarked for a particular thing like DSPs, we really must include guidelines for how the money is spent. That was our lesson in that, and I hope we've learned it well.
The next question is about a new role in our area, our system, the community health workers. Do you think the push for community health workers will be a barrier for backing financial support and curriculum for DSPs? And I'll add that as we've worked on the Meet the Need grant and been able to have wonderful discussions with people who are with DHHS, they have said that they have to be very careful about moving wages up and how that impacts or balances other areas. So I think community health workers, as they've been qualified now as care extenders, are one of those roles that they're looking at. So how do we tackle that issue?
It's a tough one. We certainly need to have care management extenders. We learned very quickly that we could not afford to have as many care managers as we would have needed in order to bring that integrated system together. And we couldn't hire people, especially in the rural parts of the state. So that's when the whole idea of care extenders came into place. And since then, the idea of community health workers has expanded that. You make a good point. The proposed wages for those folks, the wage is higher than for a DSP. DSP work is hard work. I was one long time ago, and I recall how rewarding it was. I made a lot of good friends when I was doing that work, but how hard it was, how intense it was to be the only person in home managing somebody who might have significant physical disabilities, significant behavioral issues, and so forth. So if I had a choice between a higher paying care extender position and a very much lower paying DSP positions, that's going to have an impact. And so I'm happy to know that the department is paying some attention to that. Maybe that will help encourage them to be more aggressive in requesting increase for DSPs. And they've gotten on board with this, and they've been a partner in this. But they're considering the right things. There's competition, and we happen to think DSPs are the most important service deliverers in our state. So we need to pay attention to those folks.
And I think you said an important thing that and that relates to the data, that what you're looking at is data saying community health workers are making a higher hourly rate. So yes, we should be looking at that department, but please note that DSPs are making lower than the community health worker. And these are not necessarily similar positions, but it's important to know that people may be able to qualify for each position. And so there would be that competition.
Right. That's correct.
Along with that same theme, we have a question from someone who talks about how their DSP has been with the provider for 9 years and still only makes $10 an hour. why should she stay when she can go to Target and make 15? What can be done to immediately keep her?
That is the fundamental question, isn't it? We're seeing that all across the state. COVID made that worse because people couldn't go into the homes. And so looking around, they went to Burger King or Target or other places. And lo and behold, they were able to make a higher salary, higher wages. You understand how that happened. Now, the reason that, you would think if somebody was around for 9 years, that there would be a career ladder or a wage increase. We don't have that in our state. We don't, that is, so pay doesn't equate to experience. Pay doesn't equate to training. And what we end up having are individuals who have worked, committed, done a great job. They're the folks that we want to stay in the system. And the only way we can get them to stay is what we're talking about today. The increasing wages is it. It is what we need to do. Again, secondary to that, career ladder required training, and experience tied to wages. That is, somebody's been in the system for 9 years. They ought to make more money than somebody who's just entered the system. And that will be one of the next steps after increasing wages.
Just to add on to that, one thing I've noticed is that a lot of the people who do advocacy, such as yourself, are former DSPs. And I heard one person say that the reason he took the job is because it paid more than McDonald's. And I kind of feel like we have to get back to that.
We do. During COVID, McDonald's and Target had a hard time hiring people. And so they had hiring bonuses and they increased the amount of money, and they paid people to go to take college classes. There were a lot of incentives for those folks. And we have to consider that. I mean, we have to consider the whole package if we are serious about recruiting and maintaining these essential staff. And the first blast about that is to convince the public, the policy makers, the General Assembly, and all those folks that are in a decision-making position, whether it be support or whether it be funding, whether it be the development of policy. We have to convince them that this is, in fact, a true crisis. If you don't have DSPs, you don't have services. It's as simple as that.
There was also a question, I think many of us have seen the news that the state budget came out. They separated out Medicaid expansion, but the state budget part is there. And a question about what it did for wages. And then there was a response as well that the state budget talked about paying $15 per hour, but did not supply enough funds in that line item to reach the $15 per hour. So the average now is around $13 to $13.50 per hour with the enhanced rates from the state and federal dollars. So I don't know if you want to say more, Pat, about the state budget and what do we need to do from here since it just came out?
Yeah, I'll say a couple of things. The first thing is this is a tentative budget. The House nor the Senate have voted on it yet. And so it's difficult to make any statement that's hard and fast about a budget that hasn't been voted on and ratified. What I'll say is I can talk about the innovations piece. And again, there's some increase for private duty nurses and for PCS. As I was reading through, I saw that. The language about innovations waiver is in there. Part two, we'll talk about all of this, but the data showed us that we used let me first start by saying that we used the base salary in state facilities as a benchmark. And so that was $18 an hour. What our data showed is that we would need $90 million of state money, which would draw down the federal money, the federal match. That's what we needed to go to $18 an hour. What the House and Senate have been saying, they've been going back and forth between 75 million and 60 million. Obviously, if we need 90 million and we get 60 million, what that means is that the wage increase is going to be less than what we wanted it to be. What that means is that we're going to have to double down in the next session to demonstrate that we appreciate that money, but it's not enough. And we'll have to figure out with that money how far it can go. And that happens more often than not with the General Assembly. They frequently don't meet the request with an appropriation. So we'll figure how to do that. I'll add quickly that what we wanted to request was a cost of living adjustment. And as I mentioned at the beginning, that means an automatic increase based on a lot of factors, a complex formula. But what that means is that every year there's the potential of an automatic pay increase. It's what they have in the state facilities. And what that means for us is that we wouldn't have to go back every year and say, we need this, we need more, we need more. So when we go back to the General Assembly, and I believe we will, what we'll need to do is talk about COLA, and we'll talk about achieving the goal that we set for this session if they don't come up with the $90 million.
And did it include, I have not seen it yet, did it include something about what you were talking about how much an employer can keep and how much has to go to the DSP?
Yes, it did. It included at least, and again, I just scanned this last night. It did include at least an attestation. What that means is for any provider who gets this money, they attest to the fact that 80% of it goes directly to the DSPs and 20% will go for administrative costs, but those administrative costs are restricted to solely to wage increases for the DSPs. That is payroll taxes or other kinds of things that are necessary to make sure that wage increase goes forward. They can't use it for executive staffs or IT issues or transportation issues. It's used for DSP support. That's what was requested. I saw some language in there about attestation and maybe a little bit of language saying the department can go in and assess to make sure that that's the way the money is being spent. I'm not sure there was any guidance about that, about the 80-20. Some folks wanted 70-30, others wanted another 75-25. I'm not sure what they said. I hope they put in some guidance about that. What I'll say is if they didn't, then the authority goes to the Department of Health and Human Services. It becomes an operational requirement, and the department can set those guidelines and set how folks are going to be held accountable. And that's absolutely essential. You know, I believe providers are committed to this. If they can't recruit and maintain DSPs, they're in big trouble. And so I believe they want to do the right thing. And I believe they will, but you know, trust but verify is what we need to do in North Carolina.
Next question, if there is a paid increase for DSPs, would family members who've taken on the role of a DSP also receive that pay increase?
I believe so. I believe anybody who serves as a DSP will have their wages increased, because the way the wages get increased is that rates get increased. And so what happens is that the per member per month for an LME MCO gets increased. That, the LME MCOs don't get any money for this, by the way. This flows through the LME MCO to the provider. And so that's what happens. That's the short answer.
So Pat, we're kind of running up on our 1 o'clock time frame to end, but I wanted to ask, maybe ending this on some promising notes that you can see, like, where are the opportunities that we have in all of this transition that we're doing in Medicaid transformation, focusing on integrated care that will bring in more robust data for us in the state. The tailored care management and the assessments, the 1915 I-services and the assessments that are being done. We should know better who is being served and what their needs are. But I don't know, what do you see as opportunities for us at this point?
Well, I think we have a lot of opportunities. Some good things are happening in the state. We just need to make sure that we have some balance. By that, I mean, we'll know more about what people need. We'll know more about integrated care. We'll know more about constructs, that is, the role of the LME MCO, the role of the department, the role of the provider, and what that means for DSPs and for families, and most importantly, for individuals. Sometimes, though, that doesn't translate into who's delivering the service. That's all been shoved aside for years and years and years, even though we saw a growing problem with recruiting and maintaining DSPs. There was not a focus on that. Certainly no data was being collected. So we're going to have to request and require that, not just what people need, but how those needs are going to be addressed. And we know that 80 to 85% of the services through the innovations waiver are delivered by DSPs. So that's an interesting correlation that we need to look at. We'll need to be very specific about the data we collect.
Well, Pat, we've so enjoyed this presentation today, and we all have learned so much. I know even the people within the Innovations DSP workforce group say they learned. You speak that, and we're so looking forward also to part 2, where we're going to launch from this point, now that we've got that level setting of information about DSPs, and see what we can do about them. But we can't thank you enough for your time today. And we thank everyone for joining us at the table, whether this was your first one or one of many. We try to create the space for everyone to feel included and heard. Thank you to, of course, to our interpreters and translators and court captioner. And we look forward to next month, but please look for your September Meet the Need newsletter by the end of the month, because that will include Pat's slides and also recording of this webinar. And it also has others that are on our website, which is meettheneednc.org. See you all next month, and be well. And we appreciate everyone's dedication, all the advisory council members who contribute to this, the land advisory council members, the Meet the Need advisory council members, and just everyone who makes this possible. Thank you so much. Bye for now.